Thank you, Dr. Prashant, and thanks Inasal for inviting me. So today I would like to, the pediatricians are very well aware of all the things about PFIC, nothing extra to give to them within 15 minutes or so. But I have kept my focus more on the adolescent and adults part, thinking this was from the Inasal, and also because we are also seeing these patients when they are growing up now, beyond 18 years, we are following up them till like 20 to 25 years. So today I'll keep my outlines like the various genetic intrahepatic cholestasis, when to suspect and how to diagnose is by my main emphasis, especially when presenting as adolescent and adults, and management including the novel targets. So these are the various PFICs. This I think everyone is aware about. This everyone is aware about that mainly it is the defects at the canaliculi, and then there are defects in the transporting the transporters. And there are defects in the tight junctions, and there are defects in the regulators like FXR. So if we go at the canaliculi, this is important because these three are the common ones which will present in adolescents or adults. So the ABCB, that is BSEP, this transports the bile salt outside the hepatocyte. Hepatocyte is below this membrane, and canaliculi is after this membrane. So it transports the bile salt outside into the canaliculi. The ABCB4 transports the phosphatidylcholine outside the canaliculi, and cholesterol is transported by ABCG5. So this bile salt combines with aminophospholipid to form micelles, and this micelles is required to keep cholesterol in a dissolved form. So suppose if there is defect in BSEP, bile salt will not go out, bile salt will remain in liver. So it will be more of a hepatocellular injury. Although it is cholestasis, it will be more of a hepatocellular injury. You will find high AST-ALT. If MDR3 is not going out, now that will mean bile salt will remain in the canaliculi but will not be micelles. So this bile salt will now damage the canaliculi or the biliary tree. So this will be more of a cholangiole injury or biliary injury, not a hepatocellular injury with high GGT. So this is how it is different. This inset show how the canalicular, the protein should be located at the canalicular membrane in the inset, and the larger part is the pathology where the BSEP or MDR3 are absent. So the distribution, yes, the three which I showed along with TJP2 are the four most common types of PFIC, if you want to call them that, whether we see our data at ILBS or we see the data from the Indian PFIC registry, it's the same. Most important part, when to suspect. Now in children it is very easy. The first four, FIC, BSEP, TJP2 and FXR will present with infantile cholestasis. I am showing the data from the registry which shows that almost 80% will present with infantile cholestasis. That means within the first 6 months of life. The next two, MYO5B and USP53 in green, will not usually present in early infancy. They will present in late infancy or in early childhood, but will have almost similar symptoms. They will be milder and they will have much better outcome. You can see the native liver survival is 100 to 86% till the last follow-up that they were with us. In contrast, if you see the outcomes of BSEP, FIC1, etc., you find that only 20 to 50% make it beyond their 10 to 15 years of life, and FXR, the mortality is very high. Now coming to the yellow part, that is important, the MDR3 and KIF12, these can present at any time. In fact, for 30 to 40% of MDR3 or KIF12 will present in early adulthood after 18 years of life. They will not have that severe pruritus. You can see the pruritus is only 20% in MDR3 or KIF12, but they'll have severe portal hypertension. And you can see that the advanced fibrosis was present in 85% of MDR3 in the registry data that we have. So this is how MDR3 and KIF12 are different at the age of onset and advanced fibrosis. So what will be the spectrum in adults? It will vary depending on the genetic variants that are present. Now the patient can have a mild heterozygous variant on this extreme, or can have a homozygous or compound heterozygous, that is called biallelic loss of function variants on this extreme. Now the symptoms can range from acute cholestasis like in ICP, intrahepatic cholestasis of pregnancy, or DILI. It can be episodic, or it can be the most severe form, that is presenting as cirrhosis and portal hypertension. Now DILI, it has been shown that several of the drugs are strong or weak inhibitors of BSEP, and these are some of the common drugs, mind you. And these drugs, which are strong or weak inhibitors of BSEP, were shown are among the drugs which come with a black box warning or warning with precautions as per FDA. So this is important, and this can be seen from this series also, that patients with DILI, when they are examined, it was more likely that they have variants in ABCB11, and you have to be careful with the common drugs like amoxicillin, clavulanic acid, piperacillin, tazobactam, OCPs, androgenic steroids, etc., which can precipitate severe BSEP deficiency in these patients and leading to symptoms. ICP is something very interesting. Now, not every woman develops cholestasis during pregnancy, but those who develop cholestasis during pregnancy are found to have very high levels of 5 PM5S, that is 5 pregnant, it is a derivative of progesterone, and this is very high during the late pregnancy in those women who develop intrahepatic cholestasis of pregnancy, and is normal in those who do not develop ICP. And it has been shown that if you inject this progesterone derivative along with cholic acid, the serum bile acid shoots up almost 8 to 9 times. In addition, it has been shown in my study that the another hormone, that is estradiol, increases as the pregnancy advances in the mice. This is in the mice study, and comes down immediately after delivery. In combination with this, the BSEP expression goes down as the estradiol increases, and then it comes up after the delivery. That means estradiol high is directly inversely correlated with low BSEP. So that is what is shown in these several studies, that in patients with ICP, if you do a genetic analysis, in almost 14 to 28%, you will find mutations in ABCB4 or ABCB11, that is BSEP or MDR3. But that is not the end of it. You can find any mutations actually in them. And this is from the registry data. We looked other way around, that what percentage of patients submitted to us had mothers with history of ICP, and as expected, we found that BSEP and MDR3 patients had history of ICP in their mothers in more than 20%, but important thing to note that all other types also had 10 to 15% of history of mothers having ICP. So it is not restricted to BSEP or MDR3. Any type of PFIC, any type of these variants, if present in heterozygous state, that is in mothers, can present with intrahepatic cholestasis of pregnancy. Important thing to note is, if the ICP is severe, that means if the bile acid is more than 40, it is associated with poor fetal outcome, and it is associated with the small risk of development of cholangiocarcinoma and biliary cirrhosis later in 10 to 15 years later. Coming to low phospholipid associated cholelithiasis. Now, low phospholipid means the bile will have low phospholipid. Why will it have low phospholipid? Because MDR3 is deficient, phospholipid cannot come out, so the bile is only having bile salt and cholesterol and will form stone, but phospholipid is not there. And for this, you need to suspect this when you are having recurrent cholesterol stones very early in adolescent or young adults, recurrent positive family history. This is very important. Intrahepatic calculi, this is very important for low phospholipid associated cholelithiasis, and obviously exacerbation and recurrence after cholecystectomy. Prevalence is again varying between 30 to, it can vary between 15 to as many as 50%. But this is more common only with MDR3, ABCB4. And the last part is cryptogenic cirrhosis. When you have cryptogenic cirrhosis or any cirrhosis not responding to treatment in adults, then look for these mutations. You may find them in heterozygous state or even in homozygous state in as many as 18 to 30% of these cases. I will not go in with this case because the time is short, but to summarize this case, we saw a 16-year-old child with autoimmune hepatitis, started him on treatment, was not responding well, lost to compliance during the COVID years, and then came to us at 22 years of age with severe pruritus, increasing bilirubin, progressive portal hypertension, and upper GI bleed. At this time point where the pruritus was severe, we started thinking about PFIC3. We did the explant showed a deficiency of MDR3, and the genetics which was sent came after the liver transplant, and it came as MDR3 compound heterozygous. So there were some pointers which we missed in this case, like family history of a CLD death was missed by us. There was mild pruritus. We thought it was due to overlap syndrome. We did not give it that kind of importance, and inadequate response to specific treatment was not given sufficient importance. So now ESL has come up with these guidelines. When do you do genetic testing in CLD in adults? If it is acute cholestasis, ICP, if it is severe ICP, bile acids more than 40, or if it is early onset ICP before 32 weeks of gestation, then you do it. Any cryptogenic cholestatic cirrhosis, you do it. LPAC, do it. Family history of liver disease, do it. What I will add to these guidelines from ESL is all patients labeled as small duct PSC, I believe, or I may have reasons to believe that there is nothing called small duct PSC, and they may actually be all be PFIC3, because if you see the biopsy of PFIC3 in adults, all you find is small bile duct hyperplasia, ductular proliferation. So these may be falsely being labeled possibly as small duct PSC. Again, if you're not getting response to your standard treatment, especially in AIH, look for PFIC3. How to diagnose? Always add serum bile acid. It has prognostic significance. Always add it in your LFT. This should be a part of LFT, serum bile acids. Ask for GGT because it can differentiate between high and low GGT. Liver biopsy is losing its relevance. I cannot comment here whether it is important or not, but if you have to do the genetic sequence, go for whole exome sequence, or if you are going for targeted sequence, be sure that all the genes are covered in those panel which they are offering you. Sanger sequencing, you cannot go in the first go because all of these disorders will have similar symptoms. You cannot differentiate between them. Sanger is only once you have the one family member with a known disease, and only then you can go for Sanger sequence. So it should be whole exome or targeted sequencing. Coming to the treatment, yes, UDCA is one of the drugs which is being used widely. UDCA acts if there is some functional protein remaining. There is some functional MDR, some functional BSEP, then it will increase it will add hydrofolic acid, it will increase the transport, and it will help. But coming to the important drug that we need is IBAT inhibitors. Now, IBAT inhibitors it will interrupt the enterohepatic circulation. So normally enterohepatic circulation, 95% of bile acids excreted from the biliary tree get reabsorbed in the intestinal epithelium and goes back to the liver, and 5% is excreted in feces. Now if you give IBAT inhibitors and block this absorption, more than 50% of bile acids will be lost in feces. So this is a kind of medical interruption of enterohepatic circulation. So when this drug comes in, the most important thing is we need this drug to come into India, and Inasal may have a role in hastening this process. It will come subsequently, but it has to come early because our patients are losing out on this wonderful drug. So current status, Odevixibat and Marilixibat are the two IBAT inhibitors, and they have been now received FDA approval for even PFIC in Europe as well as in the US. 3 important studies, the phase 3 studies, which have shown that they improve pruritus and they even improve long-term native liver survivor. Obviously, when the missense mutation, their response is better. In protein truncating mutations, even their response is not as good as we see in the other milder mutations. So these are the 2 drugs, Marilixibat and Odevixibat, and 2 important trials, the Indigo trial, PEDFIC1 and PEDFIC2 trial. The emphasis is on decreasing the bile acids, improving the growth, and possibly improving the native liver survival. And one important role of ASBT inhibitor is this PFIC1. We are all scared of doing transplantation for FIC1 because we know that the graft will develop steatosis, patient will have chronic diarrhea, his growth will not improve. Now the RELA team is doing total biliary diversion along with the transplant, and that is doing wonderfully well for them as of now. But the Europe have moved ahead to transplant followed by ASBT inhibitor. So you block this. You don't need to do total biliary diversion. So that is why again ASBT inhibitors are very important for us to get. Management of pruritus, yes, you will start with UDCA, but rifampicin, I need to emphasize here, whatever your level of AST, ALT, rifampicin is safe in cholestatic hepatitis, and it is a wonderful drug for resolution of pruritus. Surgical biliary diversion, yes, we have been using. The most common one that we use is internal biliary diversion. The data that we have also points to that around PIBD is 90% and external biliary diversion is only 10% in India. But this will become obsolete in coming 2 to 3 years once the ASBT inhibitors are there. You don't want to subject your patient to such a surgery where you are losing out on the bile acids. Newer therapeutic agents are all basically chemical chaperones or based on gene therapy. Gene therapy may have a role, especially where AAV vector which has liver tropism and has been successful in several other mice studies. I would refer everyone to read this paper where it has been very well described in a review, especially for the adults, how the patients who progress from pediatric to adult liver disease behave. And I also refer to this paper from the Indian PFIC registry because it's the first paper and determines how the genotype affects the outcome. There are a couple of other papers which have come, which I am not pointing out here. So to conclude, suspect genetic intrahepatic cholestasis in all children with infantile cholestasis or cryptogenic cirrhosis, but in adults, suspect when there is severe or early ICP, LPAC, any cryptogenic cirrhosis or any cirrhosis which is not responding to your standard treatment. If you have any doubt, do a genetic test. How? Whole exome or targeted sequencing. Always do serum bile acid because it will prognosticate. Treatment, yes, UDCA we have till now, surgical biliary diversion, but ASBT inhibitors is the way forward. So that is it, and I invite even the adults now, adult teams of INASL to join our Indian PFIC registry, because we have now put it to our ethics committee to include centers with having adult patients beyond 18 years of age. Thank you.